Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through hematology and oncology pharmacology. So let's start with hematology. Hematology is dealing with our blood. Obviously, we deal with this in a lot of different ways, but today we're talking about a few specific diseases. So let's start with anemia. Anemia is a state of reduced red blood cells, hemoglobin, or hematocrit, or some combination of the above. There are a few specific types of anemias, and I'm just giving you a very brief overview just so that we can understand enough to go through our pharmacology. First, we have iron deficiency anemia. Iron is the key component of hemoglobin. So if a patient has iron deficiency anemia, they're going to have a problem with their hemoglobin. Since hemoglobin is the primary component in the body that's responsible for carrying oxygen in our blood and to deliver to all of our cells, that becomes a major problem. B12 deficiency anemia is another type of anemia. This is where a patient does not have a proper amount of B12 in their body. And this could be from one of two problems. B12 deficiency anemia could be from lack of intake of B12, and that could be a dietary issue, which is common among vegetarians or vegans, because on a strict vegan diet, you're not going to get any B12 unless you supplement or are eating fortified foods, grains, etc., because B12 comes almost exclusively from animal products. The second type of B12 deficiency anemia, so one was dietary, and we just said which population is at risk for it. The second type of B12 deficiency anemia is someone who has a lack of IF. IF is intrinsic factor, and intrinsic factor is what the body, the GI system, needs in order to process and utilize the B12 that we eat. If someone has intrinsic factor deficiency, then no matter how much B12 they eat, their body cannot process it. So there's two different types of B12 deficiency, and the thing here to know is that it's two different solutions. For the vegetarian, it's eat the fortified foods and get supplements. For the person who has a lack of intrinsic factor, all the B12 they eat doesn't matter because their body can't use it. So they have to actually get B12, which is cyanocobalamin. They have to get that as a monthly injection or some other route that we'll talk about in a minute, but it's two different treatments. The symptoms of B12 deficiency, just an FYI in case I forget to mention this later, can develop over long periods of time. Some of them can lead to irreversible issues, and a lack of B12 can cause neurological symptoms over the long term. Next, we have folate deficiency anemia. Folate deficiency is easily fixed by the patient supplementing with folic acid. Hemolytic anemia is a group of anemias, and that could be from a lot of different things. Sickle cell disease could fall under hemolytic anemia, so there's lots of different things that could fall under that. The labs that we're going to be talking about when we talk about hematology is going to be CBC, a complete blood count. That's going to have your white blood cell, your red blood cell, your hemoglobin, your hematocrit, an iron panel. That's going to have your iron, your ferritin, your TIBC. We can also check a B12 level. We could check a folate level, things like that. Signs and symptoms, these are pretty generic, but generally speaking for anemia, we have fatigue because the patient doesn't have a lot of energy because they're not getting enough oxygen delivered to the cells to produce energy. They can be pale. They can have weakness, shortness of breath, dizziness, and tachycardia. So now let's start to talk about specific medications for the treatment of anemia. And the first one we're going to have is epoetin alpha. So let's start with this one. Epoetin alpha is actually erythropoietin. Erythropoietin is something that we all have in our body. It's produced by the kidneys, and it stimulates the production of red blood cells. That's the normal processes in our body. Kidneys produce erythropoietin. Erythropoietin stimulates red blood cell production, which is erythropoiesis, in our body, technically, specifically in the bone marrow. So that's erythropoietin. If a patient has kidney failure or some other condition going on where they're not getting enough erythropoietin and the result being they're not getting enough red blood cell production, we could give them erythropoietin, and that's epoetin alpha. When do we give it for? We give it to anemia due to chronic kidney disease or chemo or something like that. This does have a black box warning, several of them. One is that it can have multiple adverse effects if we give it to a patient that has a normal hemoglobin. Why? Because this is going to stimulate increased red blood cell production. Now, keep in mind, the more red blood cells we have, that might be good. That means the more oxygen we can carry and deliver to our cells. However, our blood still has to be a liquid. It can't be a solid. In our blood, we have some solids, we have some liquid. The liquid is called plasma, and the solids is going to be your red blood cells, your white blood cells, your platelets, all the stuff that we have in there. We need to maintain a balance, because if it ends up being all liquid, that means we're deficient on our stuff, on the red blood cells, white blood cells, things like that. And if we have too much of the red blood cells, white blood cells, our blood becomes really thick, and now it's a solid or really sludgy, and it's no longer going to flow. It needs to maintain that perfect balance. In case you didn't already know this, what I just described is what a hematocrit tests. A hematocrit, which a normal hematocrit should be roughly 45% in an average adult. It varies by gender, but a normal hematocrit of 45% means that our blood should be 45% stuff and 55% plasma or liquid. And if that ratio gets off, if it gets too liquidy, that means we're deficient on some stuff. If it gets too thick, that means we're at risk of clotting. So just keep that in mind. Just an FYI, since we're talking about labs, there's something called a 5-15-45 rule. If you've never heard that, RBC should be roughly 5. The hemoglobin should be roughly 15, and the hematocrit should be roughly 45. Just a good rule of thumb number or mechanism to remember these numbers. So when we give a patient erythropoietin, it's going to stimulate the production of red blood cells. If they already have enough, now they're just getting extra, they're going to make the blood too thick, which can lead them to clot. So the adverse effect that they can have is clotting, and that's a major issue. Plus, has a black box warning that it can have some effects related to cancer. This medication does have a number of side effects, such as hypertension, arthralgia, nausea, vomiting. This medication takes several days until it starts to take effect. And even once it starts to take effect, what does that mean? Excuse me. It means that it's going to stimulate the production of red blood cells. It's still going to be another week or two after that until you're actually going to see on a lab value that increase in red blood cells. So just FYI, if we're reassessing a patient to see how well it worked, that's not going to be right away. That's not even going to be in a few days, even though it works in a few days. The lab values won't come up for somewhere around 1 to 3 weeks is what it usually takes. Somewhere around 2 weeks is what most of the textbooks I reviewed say. This medication is by injection. That's why it says administered parenterally. Moving on, let's talk about filgrastim. Filgrastim is in a drug class called colony-stimulating factors. I only saw this in one textbook, so I didn't put it on here, but the drug class is colony-stimulating factor, and this is responsible for stimulating the production of neutrophils. Who needs us to produce neutrophils for them? This is going to be patients that are immunosuppressed because neutrophils boost your immune system or are a component of your immune system. So patients who are immunosuppressed, this could be patients that are undergoing chemotherapy, is by far the most common time where we use this. We could possibly use this if a patient's immunosuppressed from long-term steroids or some other things. The adverse effects of this medication is bone pain. And again, this is also administered parenterally. And again, even though this stimulates the production of neutrophils, you got to give it a few days until that production is significantly increased, until you'll notice in the labs that the neutrophil count went up. And again, we would use this mostly for patients who are immunosuppressed related to chemotherapy. And we'll talk about that in the second half of this video and get to oncology. Next, we have ferrous sulfate. This is for the iron deficiency anemia that we talked about very first. Ferrous sulfate is iron, and it's a required component for hemoglobin synthesis. What do we use it for? We use it for iron deficiency anemia for both treatment and prevention. Now, this medication is relatively common to take. A few things to know about it. First of all, a lot of patients will get nausea. Almost all patients will get constipation. That being said, we've gotten very smart in how we prescribe this, because most of the time it's not going to be just here's the go buy a bottle, take it every day. We'll tell patients take it every third day, or we'll have a lot of different tricks we could use for how the patients take it so that they don't end up with that constipation, because that's a really big issue with this medication. Also, this medication could cause a dark, tarry stool. That's completely normal. Nothing we need to do about it. You just need to tell the patient to expect that so that they don't freak out. This medication does have a black box warning that it needs to be kept away from children because it can cause a fatal overdose in children. When this medication is taken, it needs to be taken on an empty stomach. Now, you will have patients tell you, well, I can't take it on an empty stomach because then I get constipation, versus if I take it with food, I don't get that constipation. Well, that's great, but if you take it with food, it's also not really going to work. So it has to be taken on an empty stomach, and to deal with the constipation, we're going to talk about that. So a few more things, and then we'll talk about the patient education. When the patient is getting this treatment, usually within about 2 days, within about 24 to 48 hours, they should already feel better if they have severe iron deficiency anemia, but they're still going to keep taking this for about 2 months until we completely build up their iron stores again. And again, we test that with the iron panel, the iron, the TIBC, and the ferritin. Once we have their numbers fully corrected, and that's a typo in here, until hemoglobin is corrected, that's wrong. It's really until, it's until the hemoglobin corrected, but more accurately, we assess the ferritin and the TIBC and the iron level. Patient education. So first of all, it's going to cause constipation. That means you need to tell them to increase their fiber, increase their fluid, and increase their activity, because those are the non-pharma interventions for constipation. Second, you need to tell them not to take it with food, even though that's going to help their constipation. Third, you need to tell them that this medication is often going to be prescribed every second day, every third day, different dosage in different days, and everything we can do in order to figure out how to beat that issue of constipation. You're also going to tell the patient that they can supplement by taking an increase of iron in their diet, such as with certain meats and grains, fruits, vegetables, fortified cereals that all have iron in them. Now, this medication also can be taken with vitamin C. And when you take it with vitamin C, you're kind of increasing the dose a little bit, because the amount that your body would normally absorb out of your dose is going to go up if you take that with vitamin C. Now, it's a little bit tricky. Most textbooks that I looked at say you should take with vitamin C in order to increase that level. I'm going to caution you with that because some providers, especially specialists, will say, I'm going to tell you when you should take with vitamin C because that kind of affects the dose. And I don't want you just messing around with your dose. I'm going to mess around with your dose. I don't want the patient to do that. So generally speaking, on test banks, the ones I looked at, if it says to take it with vitamin C, that's a yes. Why? Because it increases the absorption, but just keep in mind that's not always a good thing because that could be increasing the dose and that can increase the negative effects, etc. And we already talked that it can cause dark tarry stool. That is iron deficiency anemia. Very common. Let's move on. Next, we have cyanocobalamin, which is vitamin B12. This is what we're going to use to treat B12 deficiency anemia. The mechanism of action here is that it's a required component of red blood cell creation and DNA synthesis. Now, what do we use this for? We use it for megaloblastic anemia, which is B12 anemia. This is available PO, IM, sub-Q, and intranasal. Now, let me just clarify. When a patient has acute B12 vitamin deficiency, we always treat that, at least that I'm aware of, I'm not a specialist in this, but we always treat that with IM cyanocobalamin, and almost always that's going to be a monthly dose. Once we get them more stabilized, then we can do these other options, usually intranasals where we go, to my understanding, but acute presentations, like it said, is always going to be stabilized with the IM injections. Generally, this is going to be continuing for life, and again, this is the patient that doesn't have intrinsic factor. If the patient is deficient because of diet, then we educate them on how to get it or how to supplement with fortified foods or vitamins. That wraps up hematology. Let's move on to oncology. Oncology is the treatment of cancer. Now, we're going to talk specifically chemotherapy. Now, there's three traditional methods to treat cancer: surgery, radiation, and chemotherapy. Let me give you a 2-second introduction. In most patients that are diagnosed with cancer, they're going to get two or three of these mechanisms. It's probably not going to be just one, just chemo, just radiation, or just surgery. Let me explain why. When a patient has a tumor that is malignant, that is cancerous, that we need to get rid of, this tumor is going to be millions and millions and millions of cells. If we use surgery and we get rid of 99% of the cells, that sounds great. Or if we use radiation and we get rid of 99% of the cells, or 99.9, that sounds great. With cancer, it's not. With cancer, we have to get rid of every single cell that's left because in most cases, if we leave even a few cells behind, it is going to come back in a matter of time. And that's why most of you are probably familiar with the term of remission and relapsing, because of what we left behind, regrowing back into full-blown cancer again. Because of that, we often use more than one modality in treating it. And again, the three options are chemo, which is pharmacology, treatment of cancer; radiation, which is nuclear treatment of cancer; and surgery, that one's obvious. So let's go ahead and talk about chemotherapy. Chemotherapeutics are medications used to treat cancer, often targeting the rapidly dividing cells, which is what distinguishes them from our regular healthy cells. Many of the chemotherapy drugs require special handling precautions, such as nitrile gloves, such as shielding, such as other things. I'm not going to get too into that. I don't think the NCLEX would either, but just understand the basic concepts that some of the chemotherapeutics may have that special handling restrictions, especially things like the radioactive isotopes that need shielding because of harmful effects they can have to you as the nurse. Chemotherapy, we've just said, is often used in combination with radiation therapy and or surgery. A few of the things that are universal to all the agents we're about to learn, so I listed them up here so I don't have to list them again and again under each drug. Almost all of these are teratogenic, so just assume they're all teratogenic. If a patient is pregnant and also has, unfortunately, a malignant tumor, we do need to make a decision on what's going to be the priorities or any way to save both mom and baby. Otherwise, the decisions have to be made between the patient and the provider. Next, we have nausea and vomiting. That's universal, again, to almost all of the chemotherapeutics. And in this case, we're almost always going to try to pre-treat the patient for their nausea before they even go for their chemo, because once they get nauseous, we're behind the curve. This is some of the worst nausea you can possibly imagine comes from these chemotherapeutics. We don't advertise that, but we do understand that. We do treat that. So we try to pre-medicate these patients. Immunosuppression, almost all of the drugs we're going to talk about suppress the immune system on some level or another. So these patients need to be educated to stay away from sick people, possibly wear masks, immediately report a fever, et cetera, et cetera. Alopecia, which is hair loss, is also something that's going to be common to almost all of the oncology medications we're going to discuss. So again, that's something, it's reversible. So you do need to educate, even if their hair is going to fall out, you do need to educate them that it's going to be temporary until treatment concludes. Now let's go through each of these drug classes. Again, the last four things I just said applies to almost all of these. You can just assume it applies to all of these to keep things simpler. I did put very little about each of these. One thing that's unique about oncology is that if a patient has any disease, if they have a heart disease or endocrine disease or a dermatological disease, almost all of that can be handled on some level by a primary care. Oncology is pretty much exclusively handled by a cancer doctor, by an oncologist. And the NCLEX recognizes that. We're not going to go as deep into the oncology medications as we do elsewhere. I was very brief here. Your nursing school may want to go a little bit more than I did, but we're not going to expand on it as much as we do about beta blockers or statins or opioids or any of the more common drugs that we deal with every day. So let's go through them. The first one we have, and these are in no particular order, are alkylating agents. This is cyclophosphamide. This one interferes with DNA replication. Obviously, this is a cancer medication. Next, we have the antimetabolite. Also, I've seen some of the textbook call it a folic acid antagonist. This one's methotrexate. You've probably seen this before if you've already seen our other lectures, because we talked about this in bone and joint, and we talked about this in reproductive health. Methotrexate is also a cancer drug, but it's a rheumatoid arthritis drug, which is why we talked about it in mental health, in bone and joint. Plus, it's a reproductive drug because it's used to induce abortions. How does it work? It blocks folic acid. This should be intuitive to you because you probably know that folic acid is recommended to all females trying to become pregnant. In fact, we recommend that if you're going to try for conception next month, you should already start taking folic acid daily this month, 30 days before even trying for conception, because those first few weeks is where the baby needs that folic acid, and you need to have a higher level of it before you even get to that first few weeks. Anyways, folic acid is very important for fetal development, which is why this medication is teratogenic, because it's a folic acid antagonist. Hopefully that little tangent there helps you remember all this. What do we use this for? We just said we use it for tumors, we use it for autoimmune disease, and we use it as an abortion agent. I will clarify it's an uncommonly used abortion agent. We mostly use that for ectopic pregnancies in the hospital in the emergency setting. Next, the onset of action for this medication is several weeks for rheumatoid arthritis. For cancer, I'm not actually sure what the onset would be. This is, again, some of the stuff here is rheumatoid arthritis. I'm not going to go into it again. This can cause a tremendous amount of adverse effects, just like all chemotherapeutics. Next, we have the antimetabolite pyrimidine antagonist. This is 5-FU. The mechanism of action is that it interferes with thymidine synthesis, which interferes with RNA synthesis, which again helps kill off the cancer cells. Next, we have the anti-tumor antibiotics. These are cytotoxic medications. You may see that term. I see in a bunch of textbooks use that. The drug over here is doxorubicin. And again, all of these categories have multiple drugs in them. I just put literally the number one drug for each one. This one has a known effect of cardiotoxicity, so cardiomyopathy, things like that. So I did throw that in there as well. This one, you should definitely educate your patient that it could change the bodily fluids to a reddish, orangish, brownish color so that they don't freak out when they see that happen. We're talking like saliva, urine, things like that. Next, we have the drug class, the plant alkaloid, and I've also seen this called an antimitotic, and that is vincristine. This medication works by inhibiting cell division and RNA and DNA and protein synthesis. Again, by inhibiting all of that, the cells are no longer able to reproduce, they die. And this one has the adverse effects of neuropathy and other central nervous systems signs and symptoms. Next, we have, I don't even know how to pronounce that one, so I'm not going to try the drug class, but the drug is topetican. Again, not sure I'm pronouncing that right either. This medication works by preventing DNA repair by stabilizing single-strand breaks leading to DNA damage. Again, that's a little bit complicated, but basically all of these work, or almost all of these work, by interrupting some facet of the DNA or RNA replication, leading to the cessation of the rapidly developing cancer cells. Next, we have the drug class anti-estrogen. This one's tamoxifen. This medication blocks estrogen receptors in breast tissue. We talked about SERMs in other lectures, selective estrogen receptor modulators. Technically, this would be one as well. This medication is used for the treatment and prevention of breast cancer and does have a black box warning that it increases the risk of endometrial cancer and thromboembolic events. You should recognize that anything that deals with estrogen can have increased risk of thromboembolic events. Adverse effects of this drug are hot flashes, decreased libido, and some other related endocrine and hormonal issues. Finally, we have the calcineurin inhibitor. This drug is cyclosporin. This suppresses the immune system, and this immunosuppression prevents organ rejection post-transplant. This isn't technically really a oncology drug, but I threw it in here because this is where almost every textbook I looked at covered this medication. The side effects or adverse effects are hypertension, infection, nephrotoxicity, hepatotoxicity, malignancy, and more, a whole bunch of black box warning. It's a very powerful drug. It's our classic drug in nursing school when we talk about an immunosuppressant that we use for post-transplant to prevent the rejection of the medication. We can also use steroids, which are immunosuppressive, or a few other things. Here are your references. If you have any questions, let me know. Otherwise, have a great day, and please subscribe to our channel.